It's wonderful to be here in Paris with so many friends and colleagues, and there's nothing like a fire alarm before a presentation. So first, I work in Liverpool in public health. I'm a paediatrician by training, public health doctor. And this chap is William Farr, who set up the system for death registration in England. And he also studied in Paris for part of his medical studies. And he spoke about the structural violence of the times when he calculated 65,000 children's lives lost unnecessarily in England each year. And this is what he wrote. This is incredible prose in an official government document, the equivalent of the Office for National Statistics. He spoke, he said, "The children passed through the fire to Moloch scarcely incurred more danger than is incurred by children born in several districts in our large cities. We need a strict investigation of all the circumstances of children's lives, and it might lead to important discoveries and suggest remedies for evils of which it's difficult to exaggerate the magnitude." Unfortunately, we're still having to write reports that outline adverse social conditions in the UK. Kate Pickett, who's coming tonight, part of the INRICH gang, and myself were in Parliament earlier this year where we launched this report on the cost of living crisis that we've lurched into after the pandemic in England. And in the report, we highlight routine stories of hardship faced by kids growing up in the sixth largest economy. To give you a flavour, parents using watered-down, evaporated milk because of the price of formula, kids turning up to school without shoes, teachers routinely buying shoes for pupils from school budgets, parents unable to roll up to medical appointments, parents terminating wanted pregnancies because they can't afford the costs of a new baby. And if you turn to what the situation looks like in my beloved city of Liverpool as we emerge from the pandemic, this shows rising infant mortality and a large chunk of kids experiencing adversity and really poor outcomes early in the life course. I guess one of the features of structural violence is we tend to normalize some of these societal inequalities that we see, and people get used to pictures like this to a degree. And what I want to do in this talk is outline some of the mechanisms that generate those inequalities, go through some of the history of what's happened in the UK, and turn to the policy experiments and what we can learn from them, and then finally end with some recommendations. I guess just taking a step back, we come in, according to UNICEF, the UK comes in at 27th in terms of its measure of children's health. If you like a footballing comparison, which I do, that's like Preston North End, which is in the Championship, the second tier of, where we have this kind of cognitive dissonance where we tend to think of ourselves as a Champions League type country when it comes to health outcomes. One of the reasons we do so poorly is because of the huge inequalities and because there are a large number of children living in poverty in the UK, and poor kids have particularly bad outcomes. If you look at the inequalities situation, this is Kensington in Liverpool, this is Kensington in London. In the latest data, there's over a 10-year gap in life expectancy, over a 20-year gap in healthy life expectancy for kids growing up in these different areas of the UK. I guess these are health inequalities. There's nothing natural about these differences. They're perhaps the most deadly manifestation of structural violence. Something we can do about these inequalities through the organised efforts of society. And by and large, we know what causes inequalities. Inequalities are caused by inequalities in the distribution of the main influences on health, shown here in the Dahlgren and Whitehead rainbow. I guess what we study less are the processes that give rise to inequalities in the distribution of those influences. And that comes back to issues of power, racism, some processes that are difficult to study, but also some processes that are explicit. And I'll show you some research where we've tried to follow the money and look at who are the winners and losers when it comes to important decisions that influence children's health outcomes. So I guess most of us here, and many people have set up cohorts. We're setting one up in Liverpool. We're interested in understanding and breaking this intergenerational cycle of social disadvantage, where poor adult health and social disadvantage affects the conditions into which kids are born, affecting their development, their learning, and you transfer to the next generation. Here's a more detailed logic model based upon Finn Diedrichson's model of pathways to health inequalities, showing how poverty or socioeconomic conditions structures exposure, differential exposure and susceptibility to risk factors in the material, psychosocial and behavioural domains. That leads to biological embedding of health inequalities, poverty getting under the skin, inequalities in child health early in the life course that then have differential consequences over the life course. And that's the intergenerational cycle of disadvantage. Let me show you some data. We've had a number of focusing events in the UK around environmental conditions for kids. This child, Awab, 2 years old when he died as a result of mould exposure, according to the UK coroner. This young girl, Ella, died because of her asthma through exposure to air pollution. We did this analysis in the Millennium Cohort Study, looking at how poverty affects the patterning of a whole range of early years risk factors for asthma, and how that leads to inequalities in chronic asthma as the kids become adults in Millennium. Millennium's one of our latest cohorts. People are seen every 2 years. Very, very rich data. I'll show a few studies from Millennium. If we just look at the social patterning, so this arrow here, poverty to these risk factors, this is smoking in pregnancy, massively socially patterned in Millennium. Smoking, environmental tobacco smoke in the first 3 years of life, massively socially patterned. All these lines fall on top of one another pretty much. Not being breastfed, exposure to damp. And then we did a causal mediation analysis which showed that kids, as they transition to adulthood, poor kids are about twice as likely to develop chronic asthma. And 2/3 of that inequality is explained by the social patterning and differential susceptibility to early years risk factors. Again, focusing action on the social patterning of risks in the early years for kids. And indeed, my mate Ian Sinner, who I trained with in paediatrics, who's a pulmonologist at Alder Hey, has been he wrote in the BMJ recently a template for paediatricians whereby they can write using a structured framework to landlords to try to get action on mould and adverse conditions in the household. An example of poverty proofing, I guess, but also an example of a skilled paediatrician spending his time focused on the wider determinants of children's health. We looked at poverty in Millennium, so this is, I'm going to skip through this quite quickly, but we're going to see the children every 2 years up to age 14, and what do their trajectories of exposure to poverty and adversity look like? Well, we used a group-based longitudinal model to compress all the data, to look at children's longitudinal exposure, and in the UK, almost a quarter, 23% of kids are always in poverty whenever we saw them in Millennium up to age 14. Another group that emerges, 12% of families kids always exposed to persistent mental health problems, and then 11% of kids exposed to both persistent poverty and persistent mental health problems. And then we looked at associations with outcomes at age 14, and as you'd imagine, all of the adversities we looked at are associated with worse outcomes, but particularly the 10% of kids exposed to poverty and parental mental health problems who had 6 to 8-fold increased risk of developing mental health problems themselves. Again, this is the intergenerational transfer of disadvantage. And then if you believe any of these are causal estimates, we did some population attributable fractions to answer the question, what would happen if you leveled up conditions for kids in the UK up to age 14? Basically, this shows the path for mental health problems, socio-emotional behaviour problems, suggesting we'd get rid of half of the burden of mental health problems in the population if we could act on these adversities. I just want to briefly mention the Danish studies. Anne-Marie's here. I've been working with Naya and colleagues in Naya Rod in Denmark, where you can, because there's much longer follow-up in the registry system through linked data, you can look at how poverty affects a whole range of adversities and then how that influences mortality and morbidity in adulthood. So in this study, we were able to follow up 1 million children born from 1980 onwards and capture every year reasonably good data through linkage on all of these different dimensions of adversity: deprivation, stressful events in the family, adverse family dynamics. I want to focus on what we see in terms of poverty. So first of all, do these adversities cluster with together? Well, yeah, you see with increasing disadvantage, you're more likely to be exposed to more of those adversities. And then again, we compressed all that data to an exposure at age 16 and then ran a survival analysis in the whole population, looking at patterns of mortality based upon different clusters of adversity. And here's the punchline is here in the plot. This is cumulative mortality in the whole Danish population. This is the reference group in green. Here, with a hazard ratio of 1.5, so 50% increased risk of death at any particular time point. These are families where they just had transient exposure to poverty around the time of birth. And then overlapping here are the kids who are exposed to persistent poverty up to age 16. They have double the hazard of death and the same mortality effect as losing your parents, because the stressful event line lies over that. And then these are children, small proportion of kids, 5% in Denmark, who are exposed to multiple clustered adversities. They have 4 to 5 times the hazard of death at any particular time point. Showing what we all know, that early life conditions cast a long shadow over the life course, and subsequent analyses using that data have shown that those adversities explain half of the inequality. Again, another mediation analysis. That limited set of adversities we can capture in the data explain half the inequality in adult mortality in the Danish population. So I want to change tack now to some of the powerful evidence about poverty from the English experiments over the last 20 years. So this shows poverty from 1997 onwards to almost current, up to now, pretty much. The black line. So first of all, families with kids in the UK are much more likely to be in poverty. Kids are preferentially treated when it comes to poverty. And there was huge progress in reducing child poverty, which has all been undone through subsequent administrations in the UK. The war on poverty, if you like, was an element of the English health inequality strategy, which is considered the world's biggest experiment in trying to tackle inequalities. It was implemented at scale. It involved targets, resource allocation to disadvantaged areas, the establishment of Sure Start, minimum wage, focus on adult chronic disease, so at-scale intervention to address health inequalities. Did it work? Well, I haven't got much time to go through all the data, but it did work, and the papers that Ben Barr, my colleague, and Margaret and Claire Bamborough have been involved with show this is absolute and relative inequality in men, rising, pre-inequality strategy decreasing, and then inequality increasing subsequent to the government taking their foot off the gas around 2010. We saw exactly the same pattern with infant mortality, and these were the targets. The targets were around differences in life expectancy and infant mortality. Yeah, so all of that's been scrapped. This is the Times saying how can 29% of British children be in poverty, in relative income poverty, just the other day. And all of those policies were undone at the same time as these cuts to local government budgets. Each blob here is a local area in England. This was the cut to the budget. We did this analysis in 2011. And that was Liverpool at the time, the most disadvantaged local authority. Biggest cut to its budget, systematically bigger cuts in the north of the country north of England compared to the south. And children's services were also targeted. If you look at what happened, this shows our analysis of what happened to funding per pupil, per child funding for early years prevention, most of it going on Sure Start, by deprivation quintile. So 4 times bigger cuts in the most disadvantaged areas where the greatest need was evident. What happened as a result of that? Well, we documented, and a number of people documented the unravelling of children's health in the UK. We saw infant mortality going up, and we went on to try and get some causal effects of poverty using fixed effects panel regression applied to this data. This shows infant mortality over time. All of the rise was confined to the most disadvantaged quintile. You can see this period here of a dramatic reduction in inequality in infant mortality that's undone. And in this analysis, we show that around a third of the rise in infant mortality, 600 excess infant deaths over a 3-year period, as I recall, 600 excess infant deaths attributable to child poverty. We're doing some more intersectional work on infant mortality. This is the latest data from England over the last 10 years, showing infant mortality by decile. It's around 6 in the most disadvantaged decile, just above 2 in the most affluent areas. And that's the gap, that's the inequality. So from a period of action on reducing inequalities, we've seen complete stagnation over a 10-year period. One of the most profound manifestations of this natural experiment has been what we've seen in terms of children entering the care system in England for all of the reasons that we were discussing this morning: neglect, sexual and physical abuse. And so we looked at what might be explaining those trends. It's anticipated that 10,000 children could be in care in England, so there's lots of concern. And Devora Bennett, one of our brilliant PhD students, has done a series of analyses in her PhD showing that there was a rise in inequalities in the care system, following a period of, rather like infant mortality, a narrowing of inequalities and then a rise in inequalities with children being taken into care, particularly in the most disadvantaged areas. And then we tested, in a number of papers, we tested these hypotheses that austerity could be leading to cuts to services that support children, particularly youth justice services, and that might affect kids going into care, and that also cuts to welfare support leading to rising child poverty may have contributed. And indeed, both pathways appear to be at play in the data. Poverty, the more important pathway, this shows the patterning of change in poverty and the change in kids being taken into care. And again, using local area fixed effects panel regressions models, adjusting for time-varying covariates, we estimate that around almost 10% of the rise in care entries in England over a 5-year period, where we've got poverty data, was attributable to rising child poverty. That's 10,000 extra kids in the care system, 20,000 kids on a child protection plan, around between 40 and 50,000 kids in need, they're the 3 tiers of the system in England. And this is obviously dreadful for all of the reasons we've heard previously, but also it's kind of a microcosm of systems failure at local area in England at the moment, because there's a huge amount of money. So local municipalities are at threat of becoming bankrupt, because or especially in Liverpool, for example, the lion's share of the spend for children for prevention is going on statutory services for kids in the care system, leading to this cycle of cuts to preventative budgets. So the Lancet, just pre-pandemic, said that Britain's broken, poor child health proves it. Philip Alston visited from the UN and said we're all in denial that poverty is causing misery. And we wrote in the Lancet that rises in child poverty, homelessness, food poverty, a deterioration in mental health have been observed at the same time as the reversal of investment in public services, with the biggest cuts in the most deprived areas. It's time to acknowledge the elephant in the room, the underlying causes of these trends in England, and to design appropriate policies to reverse them. Then came a pandemic, and we're not going to go into the pandemic, but although the pandemic's caused by a virus, the inequalities it generates have social causes. And as Kate and I spoke last year about the Child of the North report, we saw a supercharging of inequalities in various aspects of children's health in England. The Lancet said that we've dismally failed to protect children. And this just to show you some of the data, this shows mental health problems in kids using the NHS digital survey pre and during the pandemic, showing a rise in absolute levels of mental health problems and a rise in inequalities. And we see something similar for obesity, if you've seen those shocking plots. I guess a prerequisite to doing something is having a government that's willing to take on some of the issues. And our government was writing a white paper on inequalities, or disparities, as we're now encouraged to call them. But it was pulled, and there was a quote saying, the reason that they've pulled it is ideological. The white paper is an affront to this government's view of what makes for health. But I'm an optimist, and I think times are changing, and there's just so much scope for improving children's health, not just in Liverpool, or the north of England, but it's clear that we can do so much more to improve outcomes for kids. We've got global governance that says no poverty. We've got reports on inequalities coming out of our ears from the Black Report and the Health Divide 40 years ago in England, through our Due North report, which I've talked about a few years ago at INRICH, through the Child of the North report. Systems, generally speaking, need to act early, act on time, act together. A prerequisite to improving child health, certainly in England, is to reduce levels of child poverty. We need to invest in services proportionate to levels of need. We need better data to track the longitudinal emergence of health inequalities. And we also advocate a children's rights-based approach. I said we were 27th in terms of our ranking on children's health. As it turns out, we're 27th in the latest comparison of OECD levels of child poverty. We also we're 24th or something when it comes to public investment in the early years. So I guess to a degree, for all this talk of complexity, you get out what you put into the system to an extent. There's a fairly linear relationship between rising levels of poverty and deteriorating health outcomes for children. And finally, in Liverpool, we've implemented, working with UNICEF, a child-friendly cities type approach. As you all know, it's a beautiful document. It says the Convention on the Rights of the child will enjoy special protection and have at its disposal services dispensed under the law and through other means, allowing physical, mental, moral, spiritual and social development in a healthy and normal way with liberty and dignity. So I think a rights-based approach is maybe part of the antidote to some of the structural violence that we're witnessing affecting children. And this young girl from Liverpool spoke to MPs and set off a chain reaction of MPs wanting to outdo themselves with promises around change, and then appeared on the news recently. She's from the Liverpool Child Friendly Cities gang. So I'll stop there. Thanks for listening.
Thanks, David, for this very clear talk showing how these structural inequalities, poverty, shape our children's well-being. We have time for a couple of questions. Is there anyone who would like to start?
Hi, thank you so much for your talk. I was just wondering how you get these data out to people who make decisions about budget allocations now. You know, I mean, is your institute working on that, or how? Because there seems to be such a big divide between what the science shows and what's actually happening. And I mean, at least here, you know, there are rises in France, there are rises in child poverty, and we're still talking about budgetary cuts and certainly tax cuts, and that's the main type of policy that's been pushed forward. So, how do you change that?
Yeah, I think, you know, I think there are some empirical questions there around the translation of this type of evidence, and a challenge to the health inequalities community as to whether we've done that in the right way. Because certainly, you know, what we've seen is that it hasn't translated into and you know, the broader dialogue around vilification of the poor, and you know, we haven't had control of the narrative at all. I guess through the Child of the North work, we have set up, it's not advocacy, but we are trying to work intensively on policy translation. So as part of the Child of the North initiative, there's now an all-party parliamentary group taking forward the recommendations. We've certainly spoken to lots of people who are making policy in England, including the shadow health team and government. So I think it's tricky. I'd like to get people's advice upon, you know, as to how you do make sure that this evidence gets out there. I guess one of the things that I've found very edifying is giving some of this data to kids and to children and young people, and putting them in the same room as policymakers and asking people what they make of some of the trends and what might, you know, how have these decisions come across. And again, that's part of the giving children and young people a voice in some of these debates.
Catherine Law, University College London. Thanks, David. Very good talk. I was actually thinking about the point made this morning about this is how adults behave, so why, you know, not surprising that children behave like this too. I'm wondering what you thought about public engagement as a route to policy translation, because let's not forget that many people in the North voted this government into power in the UK, and there's massive swings from a Labour government which acted quite differently to a Conservative government which acts as it does. So I don't want to be too parochial about this as it's an international meeting, but it made me think that that actually we think a lot about policy translation. Maybe we should think about public translation, particularly in particular points of the election cycle, but just having a better informed public. And one of the few advantages of the pandemic was that people listened to science a bit more and got used to seeing data and saw it every day on their televisions. And therefore, they may be more receptive to looking at some of these numeric data as well as the qualitative stories that also abound in this field. So I wondered what you thought about that as an additional way, a complementary way of working with policymakers. I mean, your point about working with children and policymakers is part of that, I suppose.
Yeah, I mean, I suppose it's similar response to earlier, that we're trying to empower. You know, I think the trouble with some of this quite complex financial data is that it wasn't evident until people did the distributional analyses, and often that was academics, that you saw these patterns in the data. You know, there are very strong arguments for health equity impact of policies more broadly, but that just didn't happen. You know, I don't know the extent to which people were aware that, you know, and by the time it became evident, when all the children's centres were being shut in a particular place, it was kind of too late to influence the decisions. So, you know, I think working with populations and making sure that some of this, we've created an open source website with all of the data on different aspects of spending that's great for researchers, but also people can use for discussions with policymakers and things like that.
Well, final question.
David, thanks. That was brilliant, as always. You made a comment about structural violence, and I'm just wondering about what we do in the meantime while we're waiting for policy to be translated, about the real issue with policy to practice and the fact that for people living in adversity, they really struggle to use mainstream services. They struggle to use a health service. They struggle to understand housing forms and how you address your housing, which is resulting in people super-proofing. And what are we going to do in the meantime in terms of at least getting the services that are supposed to be providing care to people to actually start thinking about providing it equitably?
There are no
stop that.
services.
Stop that. What do you mean?
Yeah, it's an important. I mean, I guess for me, what we're doing in the, you can reduce levels of child poverty overnight. It's sometimes these things are framed as tricky things to do, but we saw in the UK that certain the elderly were totally protected over the period subsequent to the recession. One of the quickest wins for public, it's quicker to reduce child poverty than sequencing the genome of all the babies that we're trying to do at the moment. There are all sorts of things that we are trying to do that are much more complicated than this. So I think there is something about winning the political argument. But then services, certainly where I work and in other places, are, there's all sorts of really, I guess. Poverty proofing is the umbrella term that many people have been using, but it's the example I gave. It's school teachers buying fridges and electricity and shoes for children in school, and we've got poverty proofing in school settings. We've got poverty proofing in hospitals. The Children's Hospital where I work has a poverty strategy now. Again, should this be core business of teachers or paediatricians? But in the UK, I think the problems become too big to ignore, essentially. You can't treat someone's diabetes without making sure the kids have enough to eat, etc. So it's got to a stage where that's happening. I mean, I wonder what poverty proofing at a city-state level might look like. In the absence of government action on some of these things, what can a local area do to provide high-quality, proportionate to need services? And that, again, that's about joining up sectors, etc.
Okay, thank you again, David.